Welcome to the deep dive. Think about your horse for a second. Maybe that older campaigner still got that spark, right? Or your performance horse, looking absolutely top-notch. They seem totally healthy. But sometimes there can be these little subtle signs, or maybe nothing you can even see, that hints something else is going on. Today, we're diving deep into something vets see pretty often in horses: equine aortic regurgitation. You might hear it called AR, sometimes aortic insufficiency, or AI. Our goal here is to really get into the weeds on this common heart finding. We'll break down what it is, how it's found, how it's managed, and, what the future looks like for horses with AR. We want you to finish this feeling really informed, maybe even uncovering some surprising facts that honestly it could change how you think about your horse's heart health.
Absolutely. And the information we're drawing on today comes straight from solid veterinary research and clinical guidelines. So it's practical, thorough, and definitely current thinking on equine cardiology, specifically AR.
Okay, let's really get into it then. Aortic regurgitation in horses. What's actually happening inside the heart?
Right. So aortic regurgitation, or AR, it's basically when the aortic valve isn't doing its job perfectly. This valve sits between the main pumping chamber, the left ventricle, and the aorta, which is the big artery taking blood out to the body.
Okay.
And during diastole, that's when the heart relaxes and fills this valve is supposed to close completely. With AR, it doesn't quite seal shut.
So it leaks.
Exactly. Well, it leaks backward from the aorta back into the left ventricle. This creates what we call a volume overload in that chamber. It's getting more blood than it should.
Volume overload.
Yeah.
Okay. So what does that actually mean for the horse? And what causes this leak to start? Is it something sudden or does it build up?
Good questions. Usually a gradual thing. By far, the most common cause, especially in older horses, say over 10 years old, is degenerative valve disease.
Just wear and tear, sort of.
Pretty much. It's an age-related change.
Right.
The valve leaflets, the little flaps, they start to thicken up, maybe distort a bit. These changes are happening in their structure, the extracellular matrix, and it just stops them from closing, coapting nice and tightly. But here's the really fascinating part. The heart is amazing at compensating, at least initially. The left ventricle actually starts to dilate. It gets bigger. We call this eccentric hypertrophy. It adapts to handle that extra blood volume.
So it stretches out?
Kind of, yeah. It allows the heart to keep pumping blood forward normally, often for a really long time.
Wow.
So a horse could have AR for years, literally years, and show absolutely no outward signs. It could be completely silent.
That's incredible. The heart just remodels itself. Amazing. But I guess it's not always just age, right? Are there other causes, maybe things that are more, serious?
Yes, definitely.
Yeah.
While that degenerative type is the most common, there are other, less frequent causes that can be quite severe. One is infective endocarditis. That's a nasty infection, bacterial or sometimes fungal, that actually attacks the valve leaflets.
Oh, wow.
Yeah, it causes destructive lesions, damage, leading to really sudden severe AR. These horses often go into heart failure pretty quickly and have other signs of infection too.
That sounds much more acute.
It is. Then you have congenital anomalies, which are rare defects the horse is born with, affecting the valve, and something called an aortocardiac fistula. That's an abnormal tunnel between the aorta and one of the heart chambers. It causes massive overload on the heart. Very serious.
Okay.
And there are a few other rarer things too, like the valve prolapsing or inflammation, little holes forming, or even a leaflet tearing loose.
Right.
But the degenerative and infective causes are the main ones to think about.
Right. So given that it can be so subtle, especially early on, how do vets actually find it? You mentioned the sources lay out a clear process.
They do. And it almost always starts with the most basic tool.
Yeah.
The stethoscope. Auscultation, just listening carefully to the heart.
The murmur.
Exactly. AR produces a really characteristic sound. It's a diastolic murmur.
Diastolic, meaning when the heart is relaxing.
Precisely. You hear it after the second heart sound, S2, during that pause when there's no pulse. It's best heard on the left side, usually around the fourth rib space, a bit below the shoulder point. The sound itself is often described as decrescendo. It starts louder and then fades away. And the quality, well, it can be sort of blowing or musical. Sometimes people even describe it as honking or buzzing. It's the sound of that turbulent blood leaking back.
Honking. Okay.
Yeah, it can be quite distinct. But here's the kicker, the really important thing for listeners to grasp.
Okay.
The loudness of that murmur, the grade, on that 1 to 6 scale vets use, it does not reliably tell you how bad the leak is.
Wait, really? So a loud murmur doesn't automatically mean severe AR?
Not at all. You can have a grade 5 murmur really roaring, and it might be only mild regurgitation. Conversely, a very soft grade 1 or 2 murmur could actually be associated with a significant leak.
That is genuinely surprising and so important. Okay, so if the murmur loudness isn't the whole story, what else does the vet look for during the physical exam?
Yeah, that murmur point really underscores why the rest of the exam is critical. Beyond listening, the single most telling physical sign about severity is feeling the peripheral pulses, usually the facial artery, under the jaw.
Okay, what are you feeling for?
We're looking for what are called bounding pulses, sometimes dramatically termed water hammer pulses. They feel very strong, almost forceful, and then they collapse really quickly.
Why does that happen?
It's because there's a big difference between the peak pressure, systolic, and the lowest pressure, diastolic. The diastolic pressure drops low because blood's leaking back into the heart, while the systolic stays high or even increases as the heart tries harder. That wide gap, the pulse pressure, creates that bounding feel.
Ah, I see.
And generally, the more bounding the pulse, the more severe the AR is likely to be. It's a much better indicator than just the murmur grade.
Could an owner feel that themselves, or is it subtle?
An experienced owner might notice a difference, perhaps, but it really takes a vet's trained hand to properly assess the quality and compare it, to what's normal. It's about the character, not just the rate.
Yeah.
And then, especially in more severe cases, or if the horse is heading towards heart failure, other signs might appear.
Like?
Things like exercise intolerance. Maybe the horse just can't do what it used to, tires easily. Difficulty breathing, we call that dyspnea. A faster heart rate than normal, even at rest. Sometimes weight loss or that fluid swelling underneath, the ventral edema.
Okay.
And critically, we might detect ventricular arrhythmias during the exam. Those are irregular heartbeats originating from the main pumping chambers, and they can be really serious.
So murmur, pulses, other signs, that builds the picture. But what's the definitive test? The one that really nails the diagnosis and tells you exactly how bad it is?
That, without a doubt, is echocardiography, cardiac ultrasound.
Right, the heart scan.
Yes, exactly. Using 2D and M-mode echo, we can literally see the heart working. We look for enlargement, that dilation of the left ventricle and maybe the left atrium too, those compensations we talked about. We can see the aortic valve leaflets themselves. Are they thickened? Are there growths on them, vegetations suggesting infection? Are they prolapsing?
You can see all that.
Oh, yeah. We might even see the structures around the valve vibrating because of the turbulent blood jet hitting them. And things like the mitral valve closing early or the aorta itself getting smaller during diastole, those can also be clues to severity. Then we add color flow Doppler. This is amazing. It basically paints the blood flow on the screen using colors. Red toward the probe, blue away.
Ah, so you can see the leak.
Precisely. You can see the jet of blood shooting back into the left ventricle. We can estimate how bad the leak is based on how big that jet is, how far it reaches into the ventricle. Is it just a tiny whiff under the valve, or is it a huge jet filling the chamber? And then we use other Doppler modes, pulse wave and continuous wave, to measure the speed and pattern of that backward flow. A key measurement is the pressure half-time, or PHT. Basically, a shorter PHT means the pressure between the aorta and ventricle equalizes quickly, which indicates more significant severe regurgitation.
That's incredibly detailed information. It really gives you the whole picture. Are there any other tests that add pieces to the puzzle?
Yes, definitely. Electrocardiography, the ECG, is important. A resting ECG is good for catching any underlying arrhythmias like those ventricular ones, or maybe atrial fibrillation if the heart chambers are very enlarged. Okay. But for horses that are still working, especially with moderate or maybe even severe AR, an exercising ECG is often crucial.
While they're on a treadmill or being ridden?
Exactly. Because some dangerous arrhythmias only show up when the heart is under stress. Things might look fine at rest, but during exercise, problems emerge. This is really key for safety, deciding if it's safe for the horse to continue performing.
That makes total sense. Anything else? Blood tests, x-rays?
Sure. Basic blood work can help rule out infection, or we might measure cardiac troponin levels, which can indicate damage to the heart muscle itself. Chest x-rays, thoracic radiographs, can show if the heart silhouette is enlarged overall, or if there's fluid building up in the lungs, which you see with heart failure. And sometimes measuring that pulse pressure we talked about, if it's over 60 mmHg, that's another flag suggesting likely progression.
Okay, so once you have the diagnosis, you know how severe it is. What's the plan? Does every horse with AR automatically need treatment, or does it vary a lot?
It varies hugely. Management really depends on the severity. For horses with mild AR, maybe just that soft murmur found on a routine check, No pulse changes, normal echo.
Yeah.
Often, no specific medical treatment is needed at all. It's often just an incidental finding.
So just watch it.
Pretty much. The focus is on regular monitoring. That means consistent vet checkups, maybe yearly or twice yearly. Possibly repeat echoes every year or two, just to track if anything's changing. But these horses can usually carry on with their normal lives, including athletic work. That annual checkup is really key, though, even if they seem fine.
That's definitely reassuring for those mild cases. Okay, but what if it's moderate AR? The murmur's louder, maybe those bounding pulses are starting to become noticeable on exam. How does the approach change then?
Right. With moderate AR, the monitoring definitely steps up. We're talking more frequent checks, maybe every 6 to 12 months. Those checks should really include echocardiography to track heart size and function, and often resting and especially exercising, ECGs.
To watch for those arrhythmias.
Exactly. We need to keep a close eye on whether the left ventricle is progressively dilating or if significant arrhythmias are developing. The decision about continuing athletic work becomes more individualized.
Depends on the horse and the findings.
Yes. It often hinges on that exercise ECG result. Can the heart handle the workload safely? As for medication, we typically still hold off unless the horse starts showing actual signs of heart failure or develops arrhythmias that are risky or affecting performance.
Okay, that makes sense. So then, the most worrying situation. What happens when the AR is diagnosed as severe, or if a horse, regardless of initial grade, starts showing those signs of congestive heart failure?
Yeah, that's when things get much more serious. Severe AR, or the onset of CHF, requires much more active, often aggressive, medical management, and unfortunately the outlook, the prognosis, becomes more guarded.
So what kinds of medications are used then?
It's often a combination approach. Diuretics, like furosemide, are key. They help get rid of excess fluid that builds up, relieving congestion in the lungs or swelling in the body.
To help them breathe easier.
Exactly. Then there are ACE inhibitors, drugs like enalapril, quinapril, binapril. These work by reducing what's called the afterload.
Afterload.
Yeah, it's the resistance the left ventricle has to pump against to get blood out into the aorta. By lowering that resistance, ACE inhibitors can make it a bit easier for the struggling heart to pump blood forward effectively.
Do they work well in horses?
Well, their benefit isn't quite as clearly proven in horses as it is in, say, dogs or people with similar conditions. Some horses do seem to show improvement, maybe a reduction in ventricle size on echo. But it's not a guaranteed fix. And it's really important to know they have to be stopped before competition because of medication rules. And they can sometimes cause low blood pressure, so monitoring is needed.
Right, the competition rules. Good point. What else?
If the heart muscle itself isn't contracting strongly enough, what we call myocardial dysfunction, or if heart failure is progressing, drugs called positive inotropes might be used. Pimobendan is one, digoxin is another older one. They help the heart muscle beat more forcefully.
Okay.
And crucially, if those dangerous ventricular arrhythmias are detected, then antiarrhythmic drugs are essential. Things like sotalol or lidocaine might be used to try and stabilize the heart's rhythm.
And what about the horse's activity level in these severe cases?
Activity must be restricted. Horses with severe AR, especially if they have significant arrhythmias, really should be retired from any strenuous work.
No more competing or hard riding?
Definitely not. And if they're actually in congestive heart failure, exercise needs to be severely limited or stopped completely. It's a hard conversation, but horses with significant arrhythmias or an enlarged pulmonary artery are just not safe to ride anymore. The risk of collapse or sudden death is too high.
That's a really tough reality for owners.
It is. And if the underlying cause was that infective endocarditis we mentioned, treatment involves long courses of antibiotics. But even then, the damage is often severe, and the prognosis usually remains poor. A big part of managing these cases is also owner education. Teaching owners how to feel for those bounding pulses regularly, how to monitor the heart rhythm for obvious irregularities. Anything more than a normal dropped beat needs checking and being vigilant for any subtle signs like tiring easily, faster breathing, taking longer to recover, or changes in resting heart rate. Any of those warrant an immediate call to the vet.
Right, being really observant. So if you put it all together, what's the bottom line? What's the overall outlook, the prognosis for a horse diagnosed with aortic regurgitation? It sounds like a huge spectrum.
It really is a spectrum. For horses with mild AR discovered incidentally, the prognosis is generally excellent. Many live a complete normal lifespan, continue their careers, and the condition might progress so slowly it never causes a problem.
That's great news for many.
It is. For moderate AR, the prognosis becomes more good to guarded. Many can still perform, maybe for years, but they need that closer monitoring because there's a definite increased risk of arrhythmias developing or the condition progressing to severe.
Okay. Requires more management.
Yes. And then for severe AR, the prognosis is unfortunately guarded to poor. These horses are at high risk for poor performance, becoming exercise intolerant, developing congestive heart failure, and sadly, sudden cardiac death from those fatal arrhythmias.
And once heart failure develops.
Once clinical signs of CHF appear, life expectancy drops significantly. Even with aggressive medical treatment, it's often only maybe 2 to 6 months. Factors that definitely point towards a worse prognosis include seeing that left ventricle getting progressively larger on echo, finding significant ventricular arrhythmias either at rest or during exercise, the presence of CHF itself, having infective endocarditis as the cause, or if the AR develops relatively early in the horse's life.
So younger horses don't necessarily cope better.
Not always, no. Early onset can sometimes mean a more aggressive progression.
Mm.
But the key takeaway through all of this is that regular veterinary monitoring and early detection, or at least early characterization of the severity, are absolutely crucial. They allow for appropriate management decisions to give the horse the best possible quality of life for as long as possible. And it's worth remembering, especially for older horses, sometimes other age-related problems like arthritis or metabolic issues might end up limiting their career or lifespan before the AR itself becomes truly life-threatening, particularly if it's progressing slowly.
That's a good perspective. Well, we've certainly covered a lot of ground today on equine aortic regurgitation, from, hearing that first subtle murmur to understanding the complex diagnostics and the very different paths management can take.
We really have. It highlights just how incredibly adaptive the horse's heart can be, but also how important our careful observation of the tools we have, like echocardiography, are for understanding what's truly going on inside.
Absolutely. So, as we wrap up, here's something to think about. When we dive deep into understanding a condition like AR with all its subtleties, how does that knowledge not only help us make better health decisions for the horse, but maybe also deepen our whole appreciation for their amazing physiology and perhaps guide us in the compassionate and informed choices we inevitably face as the people who care for them?